Good afternoon, everyone. My name is Omar Ramos. I am the Program Development and Operations Manager at Waterford Place Cancer Resource Center, and we want to welcome you to today's presentation on fertility options prior to treatment. Joining us today as a special guest is Dr. Erica Louden, medical doctor, reproductive endocrinologist, and infertility specialist at VIOS Fertility Institute. She is a long-term partner there and focuses on all areas of reproductive health. She conducts research on access to cancer for or access to care for cancer and infertile patients and on the novel mechanism to preserve primordial oocytes during chemo and radiation therapy. So thank you, Dr. Loudon, for joining us, and we are ready to hear your presentation.
Thank you, Mr. Ramos. Appreciate you for having us. Um, so I'm going to share my screen and we'll get started. Let me know if we can see that. Okay, so today just going to talk about fertility, fertility preservation options. And so I'm coming from BIOS, and as Mr. Ramos mentioned, we are all about helping couples or patients with infertility, but also fertility preservation, which has become a big umbrella term that encompasses patients who may have a diagnosis of cancer or even taking medications that can affect gametes or your eggs and sperm, where it can cause problems where you may have problems conceiving in the future. And so we call that VIOS Strong, because VIOS, we're all about innovation, which is what that I is. We have vision. We're very passionate to make sure that our patients get the best and excellent care that we can. And so we are part of a big consortium called the Oncofertility Consortium. And that just means that we are centered as being leaders in providing knowledge and research and supportive access to care for all patients, regardless of their age, prior to their fertility-threatening treatments. And we're doing that by being innovative, efficient, and using multidisciplinary approach, meaning I'm going to be in us as providers, we work with your oncologist, we work with your endocrinologist, we work with whoever else in your the radiology department, those to kind of coordinate what we need to do to get you from your diagnosis to preserving your fertility and seeing you on the other side of your cancer diagnosis and being survivors and being able to come back to utilize the things that we're going to talk about today. So the first question is asked is, when you hear the term or the word cancer, do cancer survivors really care about what's going on with their fertility? And so there's some research out there that was done, it was conducted, and 70% of nullogravid cancer survivors do desire children. And nullogravid, that just means a patient who's never had children, they do want to have, and that is something that they said was important for them. Of that, 6% state cancer did have a decrease on their desire, but it did not, that's not a very large number. It did not change it. At some point, they did come back to a resolution that this was important for them. Of that, also additionally in this group, 26% of patients that worried that their cancer did have worries that the cancer would decrease their fertility. And we are now aware, very well aware, that some of the therapies that we do, even though they help prolong life and get us to remission, can have effect on outcomes of pregnancy in the future. And 22% of those did discuss treatments effect on the future child. So if you were able to get pregnant, would you have children that would have higher risk of any birth defects or anomalies? And then 9% would prefer adoption over having a child with unusual health risks, was what was found in that study that was originally conducted. So out of all of these concerns of patients, they want children, but they are worried about what would happen. We came up with this term started by Teresa Woodruff in 2006, who was at Northwestern at the time. She coined that phrase oncofertility, which refers to this new field of medicine that bridges oncology and reproductive health. And so we use this as a collaborative discipline where the oncologists, as I mentioned before, need to be actively involved with us to help convey that, yes, fertility is affected, and help us co-manage together that patient what is going to be the best way to bridge them between their cancer and getting them to being able to have a quality of life measure which they desire, which is having children in the future. So our objectives today are to understand what is the epidemiology of cancer in young women and to understand what those options that may be present. And forgive me because I keep saying women, but we do fertility preservation for men as well. So why is this such a big thing? Yes, we know that cancer, when we hear that word, is very scary. And why? Well, the incidence of it is 921 per 100,000 people, especially, and I focused on here, women of reproductive age, women and men of reproductive age, 921 per 100,000 will have a new cancer diagnosis. And this is data from 2018. And then 1.8 million as far as like all age groups. And so we see that this is something that's very impactful for society as a whole. But nevertheless, even though we have all these cancer diagnoses that are coming up, our technology, our treatment modalities have become so great that the 5-year survival rate for most common cancers has increased. So what was once known as, scary that you were not going to survive and beat that, we know now that with technology, we are seeing more survivors, more people getting to that other side where they can ring the bell and be successful. That means now we have to think about life after your diagnosis, and not that that ever goes away, because we realize that you still have to be under care to get surveillance, monitoring when you are in remission. But nevertheless, because those records of mortality rates have dropped significantly and this is from 2018, it went down in 1 year by 31%, which is huge. We now want to be able to help our patients go forward and have that quality of life. So from that data, 83% of cancer patients survive their disease. And you can see from this trajectory from the other page, what I was mentioning, if we were looking back in the 70s, yes, it was very grim to have that diagnosis, but now we are getting people to that finish line of being able to have a quality life. So the background of why a little bit more is that, in 2010, 1 out of 250 adults will be childhood cancer survivors. Of that, however, we were finding that some of the therapies like radiation or chemotherapy, and specifically chemotherapy with alkylating agents, and I will discuss that on a future slide. What are some of those agents, those chemo agents that we know can cause a problem? Well, they can induce something that we call premature ovarian failure for women in a majority of patients. In addition, the radiation therapy that we give for our patients can have negative effects on the uterus, and it does that by causing scar tissue. And scar tissue can not allow an embryo or fetus to implant, so you see high rates of miscarriage in patients who've had radiation therapy. And sometimes you see just infertility for the fact that the tubes get scarred from that radiation. Sometimes this damage can be reversible in those tissues, like the uterus that I speak of, or even intestines that can occur. But in germ cells, which means your eggs and your sperm, that tissue damage is not reversible a lot of times with these agents and with radiation. So we have a new paradigm that we're trying to establish for not only our patients, but healthcare providers that know that, yes, we are surviving our diagnosis. And what happens after we survive that? The fight has already begun, and now we will have that fight continue to make sure that everything else that you dreamed about in your life can be accomplished. And so not only are oncologists with REIs seeing this as a need, we have our guiding bodies who are coming out with statements to support that. And it began in 2006, once again, and that was with American Society for Clinical Oncologists. And their statement came out that as part of education and informed consent before a cancer therapy, oncologists are encouraged to talk about the possibility of infertility with patients who are treated during their reproductive years, and to prepare them to discuss possible fertility preservation options. And so this was from American Society for Clinical Oncology, abbreviated ASCO, and they come back again in 2013 that although patients may be focused initially on their cancer diagnosis, the updated panel still was encouraging providers to advise patients of that whole thread on their fertility. And this can be done in a variety of ways, such as sperm and embryo cryopreservation or oocyte cryopreservation. And so as a result of this coming out, they kept making statements, but what we were seeing is our colleagues, and we work very closely with them, that's not their area. They don't know fertility. They know it in the backgrounds, but they don't fully understand it and how it works in those avenues to navigate it. And this is why now we partner with our oncologists, we partner with our radiologists to be able to say, hey, you have this patient, you don't have to know everything about what we will do, but do give them those first initial steps to know that you have a diagnosis. We want to get you started with your treatment. But before that, let's talk to a reproductive endocrinologist who now can give you what is the likelihood of infertility occurring and how we can mitigate that. So we want to be able to preserve that where after you survive, because once again, 83% of cancer diagnosis survive. So with VIOS Strong, which is our initiative at VIOS, and we offer comprehensive fertility service to reproductive age men and women to help them, assist them in their treatment after their cancer diagnosis. In addition, we also work with prepubertal or before puberty females. So those young girls, before they started their menstruation, it can be a little bit more challenging in that cancer diagnostic population, but we are able to assist with that as well. What do we offer now that we are collaborating with our oncologists and our radiologists who are doing these treatments that are necessary for our patients to go to survivorship? We're doing comprehensive counseling before a cancer treatment begins, and we do that within 24 to 48 hours of a diagnosis. We want our oncologists to be aware. As soon as we have a diagnosis, you can refer them directly to us, and we will go ahead and get them started on the process so that we do not delay care. We do that assessment of fertility status during that diagnostic period where we're doing counseling. We discuss what those options for parenthood after cancer looks like, because all of our patients, you start with us before you do your treatment. We freeze your eggs, your sperm, your embryos, but once you get into remission is when I would like to see my patients again. And now I want to talk to you about like, what are the next steps when you are ready to come back to utilize these embryos or frozen tissue? What is it like? What do you need to do? And what does that process look like? In addition, obviously, I was mentioning to Mr. Ramos, we don't live in a silo. And so that requires us to collaborate too with our psychologists because we want to have support systems. And I realize you have support groups, and this is just another avenue because we want you to be able to talk to other patients who've been through the same journey that have done fertility preservation. What was it like? And so we do offer that in addition with our services. And then what are those options, which is what you're here for? Well, how do we preserve your fertility? There are so many options, and it kind of depends on your diagnosis, number one. Number two, how much time do we have before you need to go to your chemo, your radiation, or your surgery? Those are the two most important things that determine which one we're going to recommend for your fertility preservation. And so those options listed here, number one are GnRH agonists. This is a medication that can help preserve fertility. So it protects the ovaries and we don't use it for men for sperm, but it protects those ovaries from those circulating agents that are in the blood. The other one is embryo cryopreservation. If you have a partner, we can go ahead and take you through a quick in vitro fertilization process where we get those eggs out, fertilize them with your partner's sperm, and we freeze embryos. Or if you don't have a partner, we are doing what's listed here is oocyte cryopreservation, where we have those eggs. It still require you to do something similar to IVF for a couple of weeks, 2 weeks, or if we need to move faster, we can do shorter. But we get those eggs and we freeze those eggs. For our prepubertal girls, so those young ladies who haven't had their first menstrual cycle, well, for that patient population, we can't take you through traditional IVF to freeze your eggs. And that's just because you have to have those eggs have gone through the cycle of stage where they're able to go through maturation process. So for those young ladies, we do ovarian cortex preservation. And this is where we will go in the operating room with your oncologist and we take a little sliver of ovarian tissue and we actually put that tissue and we preserve it for you. So in the future, when you're wanting children, we can actually transplant that tissue back, stimulate those eggs at that point. And now you have eggs that you can utilize for pregnancy. Lastly, for women is ovarian transplantation. So if you are going to have radiation to the pelvis, well, we want to move those ovaries away from that radiation because that causes damage to the tissue, as I mentioned in my introduction. you get scar tissue, and that's where your cortex is, where your ovaries, your eggs live in the ovaries. So we will be able to transplant those ovaries, moving them up higher out of the field of radiation. Sometimes we take the ovaries and we can put them underneath the skin in the arm. So there's lots of ways to do this, and it just takes us coordinating with, if you're going to have surgery anyway, we could do it at the time of your surgery for your cancer. We don't have to like delay any of your care. So what makes us unique at VIOS with our patients when we do our fertility preservation is that your consult is going to be activated immediately as soon as we get that initial contact from the oncologist, or we get it from you if you're self-referring. You know, we want to see you within 24 or 48 hours. We have a financial coordinator who works with our patients to help give you the resources for grants if you don't have insurance coverage. Guess what? There are grants out there that will reduce the cost, as well as VIOS. Obviously, this is what we do every day. We're not doing this. We're not looking to get wealthy off of this. We are wanting to help, so we offer some natural substantial discount if there is no coverage. And in addition to that, a wonderful thing about being in the state of Illinois is Illinois is one of the mandated states that is required to offer fertility preservation coverage, meaning if you have a job and you have insurance, you have fertility preservation. And so that just requires, with our financial coordinations, they will go through that with you, get things ready as far as a package so we can help move those things further. But guess what? That wouldn't be a reason why you wouldn't start, because in our program, we do have medications, some on hand that we try to get started with our patients very quickly so we can move forward with their treatment. And as I mentioned, I love working with therapists because this is can be a very overwhelming process. Not only you dealing with your diagnosis of cancer, but you now are thinking about your fertility status. And this is a process that we want to make smooth for you. So we're all about your patient experience. So we use a group. One of the groups that we use is called the Wildflower. And then lastly, as I mentioned, after your remission, we are celebrating with you when you ring the bell for your success, and we are following up with you so we can talk about your fertility status and how to move forward utilizing those cryopreserved tissues or gametes. So putting a pause there, those are some of the options, and I will go in more details. But once again, it always comes about the why. Why does this occur? Well, chemo and radiation can cause premature ovarian failure. And how does that work? Women, a lot of us don't realize, if you're not in medicine or science, that you are born with all the eggs that you'll ever have. And so those eggs have been sitting with you since you were born, before birth in your mom's uterus, and they are at this stage we call primordial follicles. They live there, and every month when you have a period, if you are of pubertal age or beyond, your body recruits eggs and they go through this cycle that's listed on the screen. By the time they get to the surface of your ovary, they have fluid around them that allows us to see them on the skin. Well, unfortunately, when we get radiation, these tissues are always actively dividing and going through a process to develop so that you can get ready for ovulation. Well, this blocks follicular maturation, where your eggs, they can get halted at this primordial stage, that very baby stage of development, from ovary eggs getting to where we can actually ovulate them every month. And when that happens, that depletes your primordial follicles, so it actually can kill off those cells. And so what we're seeing is when women get into remission after their chemo or after their radiation, some of them don't resume their menstrual cycle, which is one of the signs of premature ovarian failure occurring from the therapy. Other things that we want to consider is the need for fertility preservation is there, because we do have our children, and I mentioned those prepubertal, who are having a great survival of 70% at 5 years. But of those, a lot of them are getting chemo even at that young age. And some of those common cancers that can cause this, and that we use these alkylating agents for chemo, are things like leukemia, brain tumors, lymphomas, and the list is endless. And these are more common. These are a lot of the common ones for children. And so this is another need for why fertility preservation, specifically for children if they haven't began puberty. Remember, I would offer ovarian cortex preservation, where we take a little sliver of that child's ovary tissue and we freeze it for them, so when they are ready to have children, they're able to do so. Another mechanism, so outside of like moving that tissue of the ovary, taking slivers, is that medicine I mentioned is a GRH gonadotropin releasing hormone. VIOS just means it's the hormone that comes from the pituitary gland in the brain that causes us to stimulate and release FSH and LH that goes to our ovaries so that you can have egg growth and maturation. And for men, guess what? That same pathway is on for you. So for men, that FSH and LH is involved in sperm production and testicles. Well, when we know that you are maybe going to have a very quick time, you need to get to treatment right away, or if it's a leukemia, a lot of times you're not necessarily a candidate to go through a surgery as far as like IVF, but we can use this medicine and it decreases the perfusion of that blood that's going to have that chemo agent to the ovaries. And so this goes through one of the proteins known as sphingosine 1 phosphate. Well, reducing that perfusion to your ovaries actually protects it. And so now you don't have as many of those early follicles or sperm cells lost. So that's our very first one or second one that is kind of is not surgery, but it is something that is offered. So if I see you and we don't have time, I don't have 2 weeks, your doctor said I need to start right now, or we have a leukemia and we're worried about, we don't want you to bleed during surgery because of your leukemia, then we would do medications like that GnRH alpha agonist, which is called Lupron for you. Our second other options that are available, if mature therapies, meaning a woman who's gone through puberty or started her menstrual cycle, we're looking at embryo or oocyte cryopreservation. For men who have gone through puberty, we're looking at sperm freezing. Early stages, meaning we have, once again, a child is involved that hasn't gone through puberty, ovarian tissue cryopreservation. And then for men, because I feel like we always kind of forget about you sometimes, well, for pubertal men, you also have to go through puberty too for men to be able to get sperm. And so if you don't have puberty for a young boy who has cancer, they are working, and this is experimental and it's not standard of care for them, is testicular biopsies that now they're working on being able to like do the same thing we do with the ovarian tissue, where we can go back and be able to get sperm production after we transplant it at a later time. And then lastly, developmental is something called in vitro maturation, which goes with IVF or egg freezing. So as far as embryo cryopreservation, this is the very first line of therapy I offer for married couples or patients with a serious relationship or partner. Single women also are counseled using donor sperm, because you do have the ability, if you say, I still would like to create embryos, let's do that in that situation. And why would we want to do that? Well, we do know embryos do preserve a little bit better, about a 90% to 95% survival rate when we go back to use those embryos, which is why some single women will want to use this and get donor sperm to make embryos versus just freezing their eggs for future. It's very highly successful, and this requires about 2 weeks of your time, meaning as soon as we see you for a consultation, you will start injections of medications to grow the eggs, and then we take you to a small surgery where we aspirate those eggs. Those eggs are then frozen. All those that are mature are frozen for future use, or if we have a partner for embryo creation, we are fertilizing those eggs with the sperm, watching them grow for 5 days, because it takes 5 days to get to a blastocyst, which is the stage that an embryo will go into the uterus in the future. That is what is done, and then we're preserving it. Our next thing or next options that we have is, what if we don't have time? Once again, we have a time limitation, or maybe there's a financial limitation, because those still will exist. Well, if you're going to get radiation, this is my gold standard. Where you can take, if we can't do the embryo or egg cryopreservation, the pelvis area is usually, when we're talking about gynecological cancers or GI cancers, you're going to be getting radiation in this area where your ovaries live or your testes are going to be affected. With ovarian transposition, that surgery, essentially, and this is an ovary, this is us taking it and we're just taking a little suture and we just lift it up from one position, because your ovaries are not stagnant. They actually can move. They're kind of, for lack of better, they don't stretch, but they have a ligament, a fallopian tube and a ligament that allows us to move it from this area here close to like the pubic bone to your underneath your belly button. We actually can even, if we wanted to, we could take a portion of it and move as high as the diaphragm, which is right underneath the lungs. We just need a place where it's going to have a good blood supply, because we need to make sure blood supply is still always established, because that blood is the life source to keep your ovaries from going through cell death. And so this is just showing when we move the ovaries, we put markers so we can go back later and find those ovaries, because you wouldn't have to have a second surgery to move them back to their regular location down here. This is a pubic bone. This is the pelvis. So your ovaries typically would be down here. Well, up here we have these little silver clippers or markers that we can see on radiology. Well, if you're going to do IVF in the future, you will stimulate those ovaries. I'll be able to see them in this location and be able to track your egg development for that procedure. Or if you want to spontaneously try for conception, it also helps us to be able to just monitor your anatomy for that to occur. Another option for a lot of patients, and this I mentioned already too, this is mostly for our prepubertal girls, but it also can be used for older women as well, but it's less likely necessary in that case unless you cannot go through IVF really quickly. But if we have a time constraint and there's an age constraint, this is where we once again do that strip of ovarian cortex. We go into the OR with your surgeon, who maybe your oncologist doing the cancer remover, and we'll put them in little slivers. And then this is kind of a little picture of it. This is a whole ovary. We don't take whole ovaries, but we'll take a sample and we dip them in a process called vitrification into liquid nitrogen, and those are frozen. Now, the thing for this is a lot of times, unlike freezing individual oocytes or embryos, the ovarian tissue can preserve hundreds of primordial follicles. So when I'm doing IVF, I'm getting 8 eggs or 10 eggs. We might get 6 embryos out of that. Well, the advantage of ovarian tissue cryopreservation, as it says, is we have hundreds of primordial baby eggs present. So in the future, you'll have the ability not only to get children, but if we transplant it there, you can have your own hormones for replacement therapy for estrogen, is one of the benefits of doing that. For our men, once again, not leaving our gentlemen out, it's a little bit faster, definitely for men. You will have your consultation within 24 hours or 48 hours based off your availability, because we will get you in. And what happens is after we do some testing, you just come in and we do an ejaculated sperm sample. If there are some problems collecting, we can help with that as well, as far as like there's stimulation that can be done with electrodes, and it's not painful, that will help men be able to get ejaculated samples out. If that does not work, the ejaculated sperm samples are frozen in multiple aliquots, meaning like we'll take 100 microliters or 1 ml of that sample and freeze samples for you to be able to have children with your future partner or a donor egg source if that's what was utilized. But if those were not options and you were not able to really produce, or there's something else going on, we have TESE, which is testicular epididymis sperm seminous aspiration. We can either put a needle in, or we can go in and take a little sliver from the testes, and their sperm there is stored. Well, that is what then can be cryopreserved for men, for them to be able to utilize it in the future. So just an overview really quickly. The options are endless, and I'm going to go back to that very first slide that I had everything on, is that you can have multiple options for fertility preservation. It all comes down to the age of the patient, the time that the oncologist tells that we have before they would really want you to begin your cancer treatment. So they can range from as minimally invasive as you need medication, which is the GnRH agonist, and that will preserve. You will have to do injections of it. It can be every month or every 3 months that you would do that, and you would do it until you get out of your treatment, and we will see you after remission to go ahead and then at that point to do egg freezing or IVF. Embryo creation for couples who are, their patients who have a partner, who are married or a serious relationship, you can do embryo cryopreservation, and that takes as little as a week or 2 of stimulation with injectable gonadotropins, which is FSH and LH, like our bodies normally make, and then we freeze those for you for future use. For our prepubertal girls, ovarian cortex cryopreservation, once again, not only allows you to have children in the future, but also gives you your hormones so that you don't have a surgical menopause early. which is the other concern. For patients that may be getting radiation, additional things outside of doing that, you can actually do two of these at one time. I failed to mention that. So you might do IVF and freeze eggs or freeze embryos, but guess what? If you're also going to get radiation, you can move those ovaries in the hope that you still will resume some natural functioning of your ovaries, because it's also about not just having children, but you need those hormones for other things, as your estrogen is involved in your bone health, your cardiac health, and memory functions. So that gives us an opportunity to transplant those ovarian tissue somewhere else as well. And then lastly, sperm banking for our gentlemen, which is just an ejaculatory method, or we could do epididymis biopsies to freeze some samples of sperm for their future use. So there are so many things that are available. Our goal is just that our patients who come to us feel that they are getting the support they need in a timely manner, because at the end of the day, we want you to, I always say this, live long and prosper is my goal, and I want you to have the quality of life that you desire. So if you want children, know that it is an option. Know that you can beat this cancer, and we are here to make sure you get to that goal if that's what you desire. And I wish, if you have any questions, I think I only see a few people, and I know this is going to be aired later, but if there are questions, you can always call VIOS or an ask to speak to myself. That number is 866-585-5565, or go to our website and somebody would gladly reach out to you to answer questions. Because one of the questions that I commonly get, well, patients didn't know about this and they've already got maybe some exposure to chemo. Well, guess what? There are women who resume their menses and may not be affected yet, but you go through early menopause. I still say reach out to a reproductive endocrinologist, get tested first, your ovarian health, and you can go ahead and freeze some eggs and sperm at that point as well. It may just not be as many, but it's still better than zero. Now, are there any questions from you, Mr. Ramos?
None at all at this time. I want to thank you for providing such an amazing amount of information in such a short amount of time. Um, I was really floored by the amount of options that are available to our cancer patients, and I'm hoping that this conversation will continue. For those of you who are watching this after it's been recorded on our YouTube channel, we would love for you to connect with Dr. Louden. You can reach out to her in the ways that she's already provided, or again, you can reach out to Waterford Place and we will connect you with her immediately as well. So I want to thank Dr. Louden for coming in, sharing such a wealth of information and expertise with us and our community, and we look forward to meeting her again in the near future. Otherwise, until then, please reach out to us at our website, www.waterfordcrc.com, to learn more about our upcoming programs or to connect with me or any other staff here at Waterford Place. Thank you, and we will see you soon.
Thank you.